Welcome. Now let's talk about what happens to patients with severe sepsis and septic shock after the 3 hour, 6 hour, then what happens after that. So let's say the patient has been resuscitated, you had fluid bolused them, you started them on presses. So now the aftermath. So we'll talk about today a few things. One is vasopressor use. The next thing we'll talk about is volume status and fluid balance. The next thing we'll talk about is the vent bundle and just general features of the vent bundle if the patient's intubated. The next aspect will be nutrition. And following nutrition, we'll talk about just general housekeeping matters in the ICU. All right, let's get started. So vasopressors use. So vasopressors should be targeted for a MAP above 65. So mean arterial pressure above 65. So as long as you keep that up, you can continue to wean off the vasopressors. Most of the time, the main go-to is levofed or norepinephrine. Epinephrine as well as a quick second line. And these can be tapered down every 15 to 20 minutes due to their half-life. And so you can watch the urine output and see how their MAP as well changes. So if their MAP drops below the 65 mark, at that point you may want to gradually or even reduce the levofed or norepinephrine a little slower, or it could mean that your volume status is not adequately resuscitated or up to where you need it to be. So you can continuously do that as long as you target a MAP of above 65. Now in some patients, there will be a subset of patients where you'll see the urine output being great, even for MAP slightly below or just at 65. So the urine outputs are great. At that point, they may be perfusing well, and the MAP of 65 may be a rigid threshold. So what I tend to do is actually then drop the MAP target to above 60 so that I can wean down the presses, but continuously monitor urine output to assess for changes. And if the urine output starts dropping off as well, I may want to consider increasing the MAP again to 65. So consider adjusting your MAP targets, kind of adjusting your goalpost at times based on urine output. However, if you find that the patient's off vasopressors for at least 12 hours, you may want to consider at this point diuresing them, as we find that patients with a positive balance for prolonged during mechanical ventilation actually increases their length of time on the ventilator. So once they're off presses or they're out of shock for at least 12 hours, consider a diuresis because of obviously the initial fluid resuscitation. Now once you have started weaning off presses and so on, but also kind of trying to figure out as well if your volume status is, for example, if you're reducing vasopressors and you see that they continuously will drop their MAPs below 65, you want to assess their volume status. Now that's a little tricky in the ICU because everyone's a little different. Everyone comes in with a different fluid deficit. Everyone comes in with different cardiac status. So volume status can be a little difficult to evaluate. We used to use CVP pretty regularly. However, the CVP or the central venous pressure has been kind of a very shady goalpost. We've tried to target it, but haven't really gotten the results we wanted. What we found is newer technology or more available technology is bedside echo to evaluate the IVC. So if you see the IVC collapsibility is minimized and it still stays pretty well maintained even during expiration and inspiration of the changes on the ventilator, you know for sure the patient's probably well resuscitated at that point, so you don't want to keep on dumping fluid on them. Another thing is being introduced is the HTE, which is a new technology. It's a hemodynamic TEE. It actually looks like a esophageal echocardiogram, which is an NG tube that goes in, and you can actually monitor and look at the SVC at that point. The SVC index, which tells you how collapsible it is. That's another tool to assess for volume status. Another tool that's used is a stroke volume variation. Some of the newer machines, such as the Vigileo, uses stroke volume variation. So anything above 13% at that point may indicate the patient may need still more fluid for resuscitation. And obviously the good old passive leg raise, especially if you have an arterial line in the passive leg raise, raising both legs at a 30 to 45 degree angle, and monitoring the changes in MAP may actually indicate whether the patient still requires fluid at that point. It's kind of giving the patient a fluid bolus with their own fluid in their lower extremities. So volume status is important at this point and kind of figure out when to wean off the presses. And once you feel that the volume status is adequate, you want to maintain a fluid balance that's even or negative. The reason is, like I mentioned earlier, the more positive you are, you find that the patient then ends up being on the ventilator a lot longer or in the ICU a lot longer as well. So you want to maintain an even or negative fluid balance, but there are a couple of caveats to this. You want to make sure that there is no evidence of tissue hypoperfusion. So you want to make sure the lactic acid continuously comes down. It's not going up. So you make sure that the lactic acid continuously comes down. You don't want it going up as an indication, because if it's still tissue hypoperfusion, you don't want to diurese the patient or keep them negative, for example. So and assuming as well their fluid balance or their hemodynamic status is pretty stable, you want to consider a negative or even balance. Like I said, diuresis earlier is a great way to use. And this is a segue to the next point of it. If the patient's anuric, hemodialysis or CRRT, or another tool called sustained low efficiency dialysis, or SLED, maybe tools to use depending on the fluid balance status or even the patient's hemodynamic status. So in these cases, if patient's anuric and you're worried about their volume status, you're weaning off their presses, but they're still they're not peeing out as much as you like them to because of the renal failure that they've encountered. Hemodialysis may be the next option. So consider that as well as a possibility to kind of maintain. Again, another tool or another way to consider this if the patient has severe acidosis from their lactic acidosis as a reason to start hemodialysis in patients. The next thing that we'll talk about is the vent bundle. Now, the vent bundle, again, this is for patients who are intubated. This usually includes selective oral decontamination that's done with oral chlorhexidine twice a day. It's usually part of the vent bundle, which is pretty ubiquitous in most ICUs nowadays. The vent bundle will include, like I mentioned, oral decontamination. I hope that suffices. The next thing they usually might consider as well, depending on the availability of newer ET tubes, is subglottic suctioning, which helps reduce the amount of secretions right above the ET tube cuff, and thought to reduce ventilator-associated pneumonias or ventilator-associated vents. Now, what's simple and pretty easy to do, and we tend to avoid or forget actually in vent bundles, is the head of bed elevation. Keep the head of bed elevation at more than 30 to 45 degrees. This helps reduce ventilator-associated pneumonias. It's easy to do. It tends to work initially when we get the patient in the ICU, but as we bathe the patient, clean the patient, procedures are done, the patient ends up being in levels a lot less than 30 to 45 degrees. So keep an eye on that as well. The other stuff about the vent bundle would include GI and DVT prophylaxis, and that should come under general housekeeping as well. The next thing we'll talk about is nutrition. So nutrition is important. Now, it's important to consider initiating nutrition within 24 to 48 hours, unless there's a contraindication. You want to use enteral feeds or oral route for feedings. You want to make sure that the gut is used, because we found that even using gut and not reaching caloric requirements, daily caloric requirements, has beneficial effect. So do try to use the gut if possible. Strict contraindications would be GI surgery or any GI pathology that obviates the need to use the gut or the ability to use the gut. I generally do not touch TPN until the patient's about 5 to 7 days in, and this is also based on the Surviving Sepsis Campaign guidelines. So once you're 5 to 7 days in and you're not meeting caloric requirements, or there's still a contraindication to use the gut, you may start using TPN. TPN may be used, this is a gray area, if the patient's coming out of GI surgery or in shock and so on, they're not able to use the gut. At that point, you have to use it a case-to-case basis as well, deciding when to use TPN. But just a general idea is use the gut. There's beneficial effects of using the gut even if you do not meet full daily caloric requirements. Don't try to substitute that with IV glucose or dextrose as a means of fooling yourself into thinking that you're doing something good for the patient. All right, I hope that was clear enough. The next thing I want to talk about is residuals. We tend to stop feeds frequently because of high residuals. Now, your high residuals and my high residuals may be very different. Our ideas of high residuals may also be very different. But the American Society of Parenteral and Enteral Nutrition recommends high residuals of above 500 cc's. Now, a lot of ICUs that may come as a culture shock to hold feeds only above 500 cc's, but I'd suggest my normally target number is about 350 to 400 if I don't find the numbers above that, I generally tend to encourage the nurses to continue feeds and continue using the gut. If they're off presses, for example, I pretty aggressively go up on the feeds. However, if they're on high dose presses, I generally avoid using feeds so early on. However, if I feel like the presses are coming down pretty well, I'll go ahead and initiate feeds. Some surgeons or some other ICU doctors may have different cutoffs. I leave that to each ICU flavor. Now, just general housekeeping as well. We'll talk about steroid taper, especially, for example, if you started steroids in the patient. I generally, after about 12 to 24 hours of being off presses, I'll half the steroid dose on a daily basis. And that should mean that in the next 4 to 5 days, you should get steroids off. Unless, of course, you come in you hit a roadblock of a recurrence of the shock in the patient. The next thing is sedation. If the patient's intubated, I refer to the sedation on mechanical ventilation section or sedatives while on mechanical ventilation for further information. Glucose levels, keep them less than 180. And another thing that I want to talk about is general housekeeping as well as the goals of care. Don't forget to initiate discussions and continuously initiate discussions with the family regarding the goals of care of any changes in the patient's status. Don't wait till the next day. If something critical occurs, make sure the family knows, make sure that a point person is notified in the family, but there should be a point person as well in the ICU team or even the nursing team, or who's going to speak to the family members. So make sure, but if there's no critical changes, the patient's improving, still initiate discussion. There's been too many times that we focus on the clinical aspects, but don't give any thought to what's going on in terms of the minds of the caregivers and the loved ones at bedside. General ICU care as well will encompass something called fast hugs, BID, and I'd refer you to the section on fast hugs, BID in the ICU for general ICU care. And for further information, you can always refer to the Surviving Sepsis campaign guidelines. So just as a recap, we spoke about vasopressors today. I hope you can understand my writing. The next thing is fluid balance or volume status, nutrition, vent bundle, and I'm going to put this right up here, general ICU care. All right, thank you.